Well, thank you very much. I normally have no difficulty making myself heard, but I must use the microphone for the translator. I'm sorry if it's loud. Right. Thank you very much for Tullio and your colleagues for inviting me. It's a great honor to come here. I've been here 2 days, so I've had an opportunity to look at Trieste, and it's a lovely city and some great hospitality as well. So thank you very much for that. And as has been said, I'm going to talk about quite a lot of things to do with low-intensity psychotherapy. I hope that by the end of my talk you will understand a little more about low-intensity psychotherapy, but also appreciate the difficulties in changing a health service and a health system so that it can shape itself in this new way. First of all, I'm going to start with a joke, an American joke, by Alan Kasdin, who you may know. He said, well, you know, guys, if the goal of psychological therapies is to reach a small number of people, if the goal is to exclude those in need, particularly minority groups, particularly those in rural areas, especially those who are old, and especially those who are young, if that is our goal in psychological therapies, we're doing great. But of course he's joking, we are not doing great, because that is not our goal. But that is the neat summary of the current situation. And it's a summary that has driven my professional and academic life for the last 15 years. Tullio has already said some psychological treatments, mainly but not exclusively cognitive behavior therapy. It's mainly that we have evidence for cognitive behavior therapy, but some treatments are as good as pharmacology in depression, and they are better at treating anxiety disorders than drugs. That's a fact. Here is another fact. Only 24% of people with common mental health problems, by that we generally mean anxiety and depression, receive any treatment for their difficulties, mostly in the form of medication. Only 9% receive another form of therapy, and no more than 1% receive therapy that has got an evidence base. So there are vast numbers of people without any kind of assistance whatsoever. Well, you might say, why does that matter? Maybe these disorders are self-limiting, it's part of life, we just should get on with it. Well, already we heard about the amount of money this costs the global economy, and the global economy doesn't really have any money anymore. So it's like pouring large sums of money, and I converted I don't know the Italian figures, I converted the British figures into euros. It's like throwing a large amount of money down the toilet, because it is completely waste. The other thing that is very important to note in terms of the use of money in health services is that, as we heard, the total disability attributed to mental health disorder, more than half is generated by anxiety and depression, and less than 5% is associated with the very serious disorder of schizophrenia. Now, of course, if you have a schizophrenic problem, you require assistance, and probably over the long term. Mostly, if you think about where the mental health services money gets spent, it does not get spent here, it gets spent here. It is mostly directed at the smallest burden of disability. And I think a good reason to be concerned is that it hurts a lot when you're anxious and depressed. It is not a minor issue to be anxious or depressed. It's a very serious issue and affects many areas of your life, and it hurts like hell. And really, in the latter part of early part of the 21st century, and it's still the case in many countries, it feels like this man here staring across an abyss with no assistance to get across to the other side. That's not me. I never would dare to sit here. So, I want to introduce for the first time today this issue of access. Our work, as has been said, is called Improving Access to Psychological Treatments or Psychological Therapies. But access is a very difficult concept, and you have to pull it apart theoretically in order to think about what you do next to achieve the goal of improving it. So access principally is, of course, about availability. We must have an adequate supply. Of course, that is part of the equation. But it's also about utilization. People must actually use the supply. And this is not necessarily the same thing at all. The supply must be effective. There's no point supplying something that doesn't work. So effectiveness is also a part of the access definition. It must also be cost effective. We have to be able to afford it. And it has to achieve its worth, achieve its improvements at a sustainable cost. I think for me as well, I've always been very driven by an issue of equity, that whatever these treatments are, they should be delivered according to need, not restricted, as they are in some health systems, by your ability to pay, where you live, what your culture is, or other factors in society. And then the final definitional component is this: patient-centeredness. You have to deliver treatments that are aligned with people's preferences and their own personal needs. And that can be probably one of the biggest challenges of all. So just remember those 5 components, because they have largely driven our work and thought about how we can address those 5 components in improving access. So whilst some of it is about low-intensity psychotherapy, it is not just about low-intensity psychotherapy, and I will go through the various components in turn. But I will start here and ask a question: is this the dawning of a new paradigm? We edited this book now 3.5 years ago, and this is the first time that we went around the world and found all the authors that knew most about low-intensity, in this case cognitive behavior therapy, for which there is the largest evidence. We brought it all together in a book, and we have about 80 or 90 authors, I think, 40 or 50 chapters in this book, dealing with this really rather complex phenomena. And we wanted this the place where people could go for one stop to have a look. What is it? Well, we spent 6 months trying to agree a definition. This is part of it. It's a values-based approach. It's based on principles of social justice and equity. And it seeks to democratize access to effective, evidence-based psychological interventions. It's, for me, not all my colleagues take this view, but for me, it's very much about taking power away from entrenched professional elites and giving the power or allowing that power to be used by people with the disorder themselves. It's not concentrating knowledge in professionals, it is placing knowledge in the community. And I think for me that's one of the most important drivers behind some of my work, where I have been very much disliked by the professional elites for saying such heresy. So I'll give you an example from an Australian friend of mine who uses this example in his talks. And because he's Australian, they have a problem with rural health, as where in my part of England it's the same. So he gives this example of a lady who's 43, she's a single parent. She has a clinical depression in the moderate range, so she has a diagnosis using DSM. She works part-time as a community worker. She's got into debt, a mortgage, her payment for a house, she's in debt. And she lives 20 miles from town. In Australia, all the mental health care is concentrated in cities. And so, for her, under a traditional system, this is her option. She has to wait for psychological treatment. And she has to pay for it. And she knows the lady who is the therapist. And the therapist is only available in office hours. So because she's a single parent, she has to take time off her work, she has to find childcare, and she has to spend money driving into town and back again, 40 miles, money she doesn't have. The therapist is a private therapist, and so she isn't integrated with the mental health services. And this is a very common experience in many health systems. How do you get psychological treatment? All these barriers in front of you. And really we have operated using a model from the late 19th century. It's the same model. It doesn't matter what the orientation of the therapist is, you're generally expected to have a one-to-one treatment in a clinic. We call it the golden hour. Why? There is no sensible evidence, but an hour is what you get. In office hours, you often pay, and in systems like our state system in the UK, in the NHS, and I think maybe also in other systems like Italy, is that you have either a waiting list or you have the option of paying somebody privately, because this system does not deliver volume, and we have a volume problem. And I think that means that the current system that, I say current, the system that was operating until 2008 in the UK was ineffective, inefficient, it was discriminatory, and the question we might ask is, would everybody want this model? Is it something that they're not even given a choice anyway? Would other people prefer to learn and to grow and to have their problems advised on in a different way? And of course we think that is true. Yes, they would. So, if the purpose is to increase access to evidence-based psychological therapies, you have a number of options. Now those options, a definition is try to keep the level of intervention the smallest possible for the maximum gain. Try to minimize the amount of time a specialist spends with a patient. Try to give the patient much more choice about how the therapy is delivered, more choice than the simple old-fashioned model. And there are some examples. Also allow the patient to take their own pace, their own speed. Maybe take things in smaller amounts. And this has significant implications for the way in which the psychological therapist must act. they have to act like a sports coach, like a coaching role. They're actively working on education, and the work is being done, as an athlete would do, by the person themselves. Now, I know lots of psychotherapy traditionally takes that approach, but it is very explicit in low-intensity therapy. And here's some examples. New ways of working. Guided self-help, books, the internet. Unguided self-help. By guided, I mean there is somebody to help you with the work. I put unguided there, but actually the evidence is that that doesn't work very well. In fact, there's very strong evidence that that doesn't work very well for many people. You could do groups. Groups can be 12 people, 6 people, or they can be 120 people. We could do I know somebody in Glasgow who does mental health treatment in this size of audience. And he claims great success from this, although he hasn't, unfortunately the data is not so clear, but anyway. We might do advice clinics, and we might work through other low-intensity agents. That might be other people with these kind of problems, so peer support. It could be through librarians, could be through shop assistants, could be through lots and lots of different agents delivering these kind of advices. New times. At home, in libraries, in the evening, in advice clinics, by email, by internet, chat rooms, bulletin boards. There are many places where this can happen, different from the traditional consulting room. Here, you know, it's a list of communication tools, email. I would point out the telephone. I would argue probably that there is nobody in this room who cannot do what I just did. But some people have kind of jumped over this tool, which is fantastic. My mother, she's 77, she has one. You know, we all have a telephone, at least one. In some countries of the world, they're no longer putting cables in. It's all mobile networks. And the phone is a much, I think, missed opportunity for psychological therapy. My Australian friends are very keen on all these internet options, and I keep saying to them, don't forget the telephone. Don't forget the telephone. Don't forget people reading. These are things people want to do. More on that later. New systems. I'm going to spend quite some time later talking about stepped care. It's the title of my talk. Collaborative care, and the importance of routine outcome data monitoring is so important for our work in IAPT. But the point of this slide is we need new systems to accommodate this new way of working, and that is the big challenge for health services. We also need a new workforce, okay? If you think that in traditional psychotherapy the clinical skill is in the therapist and in the interaction between the therapist and the patient, what we often do with low-intensity techniques is place the clinical material in the clinical knowledge in the material. So in books or in computer programs or some other format, we shift the clinical technique from the psychotherapist into another medium. So that workforce needs different skills. And there's a question for you, do we still need the specialist then? Some of you, I imagine, have spent your whole lives learning to be specialist psychological therapists and may have some anxieties about me talking about taking your skills and putting them in a book. I don't know, I feel sorry for my translator. Maybe greeters not bouncers is a difficult, we didn't check it out. Has anybody had the experience of going to a nightclub and the big guy looks at you and goes, no, you can't come in? This is the experience of many patients in mental health services. Mental health services, you're not suitable for my service. What they mean is my service is not designed for you, but they say you're not suitable. So you can't go and dance in the mental health service. And this is very common, and it's of course driven by the fact if you have very limited resources, you have to say no to most people because you can't give them enough. You can't give them anything. So you have to reorientate mental health services so they become greeters. So they say, come in, have a dance, you know, enjoy being here or learn something from being here, rather than push people away. And I can tell you that is something I have argued with mental health professionals time and time again. They say, but they're not suitable. I say, well, they're distressed. Of course they are suitable. Also need to orientate around self-help and empowerment. That's less difficult. Most mental health professionals have that idea in their mind that they're trying to help people to become more empowered. But much psychological therapy encourages, traditional models do encourage inadvertently people to become dependent on the therapist, and this is not something we wish to see. And the final thing is that we give people choices. And choices, again, if you spent 20 years learning to do one type of psychotherapy, you're not well equipped to offer choices because you only really feel competent in one particular way of working. So all these things challenge mental health workers, and we've had many discussions over the years with mental health workers about how these challenges can be met and can be overcome. So, of course, the question would be, this is all very fine, Professor Richards, but does it work? Is there any point in going further without answering this question? No, of course not. So the systematic review that I will quote here is by Pim Kuipers, published in Psychological Medicine a few years ago, not so long ago. Pim Kuipers has the world's best database of psychological treatment trials reported in peer-reviewed literature. He updates it every year, and so he produces a lot of meta-analyses. This is this one. They, at that time, conducted a meta-analysis of randomized controlled trials, and I insert this because it's very important for you to know the difference between guided and unguided self-help. So this is guided self-help. What that means is that whatever materials are being worked with by the patient, they are being supported by someone with some expertise or as a coach. There's a coach involved to support them. And they looked at depression and anxiety. They compared that kind of treatment directly with face-to-face psychotherapists. And you can see the results. They've written it in a biased way because anybody who knows how a meta-analysis should be knows they said that self-help in favor of guided self-help. So they make the claim that self-help is better than face-to-face psychotherapy, but the statistics do not say this. What that means, and particularly what this means from minus to plus, is there is no difference. So really the evidence in the systematic review was that guided self-help is equally effective as face-to-face psychotherapy. And this is a reasonable number of studies and patients. Although not huge, it's a reasonable number. So the answer would be yes, it does work. So what would my friend's Australian patient experience if they were having a low-intensity service? Well, that would be the difference. They would get service within about 3 weeks. In the UK, the target is 4 weeks for our services. They would not have to pay for it, and they would not know the worker that they is guiding them. She could do it at any time. She would probably do it at home with the low-intensity worker using the telephone to support her, so she wouldn't have to pay transport. She could choose, if she had a computer and was comfortable, she could use the IT, or if she would prefer to read it from a book, she could use it in a book or download it on a tablet or something. And the goal would be the low-intensity worker integrated with community services. Now, this is quite simple in the UK and probably in Italy, but in Australia it's a real problem. But you would want the linkage to community services in the way that we are expecting in our services. Okay, so I can sit down now, right? Solved it? I don't think so. Things are never, ever that simple. And I want to talk to you about how we did it over the last 5 years in the United Kingdom. And so really we have this terrible paradox that we have treatments, but we appear absolutely unable to deliver them. And this is American data from Wayne Caton, who's a very good researcher in Seattle. And he says, I think, quite rightly, that we are only about 40 to 50% of depressed primary care patients who we refer, if there are any general practitioners here, you will have this experience, refer them to a mental health specialist, and maybe 40–50% actually turn up. You know, there's a lot of what's the word? You're somewhat put off by the message behind you're going to get mental health care. It's a barrier just by the word mental health. So maybe, you know, 40–50% actually make a visit. And then the median number of visits is only 2, which even in low intensity is probably not enough. But it's certainly in high intensity psychological therapy not enough. And the big problem for those of us who believe in evidence-based medicine is that people who do go to mental health services often do not receive evidence-based psychotherapy. They receive something which the therapist believes, but has no evidence for that belief. And that's a problem, because if we go to one therapist, you get one thing. If you go to another therapist, you get another thing. And how do we know whether that was right or not? So in the UK, we had a once-in-a-lifetime opportunity, and we're given a very large sum of money, this is a large sum of money, to improve access to psychological therapies. And it's called the IAPT program, and it started in 2008, although our research and our piloting started in some years earlier. And we got the money in 2 amounts. In 2008, we got about £400 million, which would be, I think, 500 million euros, maybe, slightly less. And then we got the rest in 2011, 12. So the question is, have we invested it wisely? And I'll let you make your judgment. Already we heard about NICE. One important thing to know about NICE is it has no legislative authority in the UK. It's a guidance organisation only. But because we have a national health service, people who are paying money to commission health services can use the NICE guidelines as a means of commissioning services that meet those criteria. So it's extremely powerful in the way our health services are commissioned. The other thing that's important about NICE is it is independent. Many guideline development groups, many guidelines are developed by professional bodies, and so there's always conflict of interest. Now, although NICE does have professionals sitting on its committees, it is independent. It conducts meta-analyses of the data independently, presents those to committees, and they come up with a decision. I think it's very important that you understand that NICE is not run by the Royal College of Psychiatrists or the British Psychological Association or Society or some other body. It is an independent body funded by the government. And as we already heard, NICE recommended a series of evidence-based psychological treatments should be available in the UK to anybody with depression and anxiety. The problem was nobody was getting it. So they came out with guidance in 2004, 10 years ago, and the health service was facing a big problem. They have this guidance, which is very important, but nobody is following it. So we then got into arguments with the government to fund these additional services. And before we got the money, a number of health trusts were trying quite hard to do this, to follow NICE guidelines, and really struggling to do so without investment. And so we argued very strongly for investment. And what happens is that we set up new high-volume clinical services for depression were set up nationally. When I say nationally, only in England. You know, the United Kingdom is this bizarre country where Scotland is not yet independent but kind of is, and Wales is not going to be independent but acts like it is, and now we have Cornwall which wants to be independent. And the National Health Service is a national health service, but these guidelines and these services only exist in England. So my colleagues in Scotland and Wales are rather upset because their health system hasn't gone down this way. So that's what I mean nationally. We spent our money on training 6,000 new mental health workers. This is a big investment and a big effort. We trained them in evidence-based psychological therapies. We then asked those services to organize themselves using several principles: low intensity and stepped care, up to high intensity. And don't worry, I will explain what all those mean. What we had to do was create a new paraprofessional group that had not existed before, completely new mental health workforce, specifically for low intensity delivery. Because we feared, and I think we were right, that the existing mental health workers would not do the job. They would continue to do what they were trained to do, which is some form of high-intensity psychotherapy. They would not do this new job. And we had to train a whole new workforce to do that. And here's one of them. So this is a IAPT mental health facility. And as you can see, high use of IT, high use of telephone. Here's another picture of the same outfit. This is taken from the first pilot site in the north of England. I hope you can see this. We have a mental health worker with a disability working here. All right, now that's much easier for him to work in this kind of environment than if he was having to move around clinic to clinic to clinic. He can work. He would not mind me telling you, but he was not professionally qualified, and neither was this lady here. They were specifically trained to do this job by our research team in the University of York. So some important hidden messages in those photographs. So I'm going to tell you about the architecture of the English system. Telephony, I've already talked about, is very important. 75% of contacts are through the telephone. Evidence-based treatments, already told you about, very important. What they do has some scientific basis. We had to train people to be competent, very big program of education. Smart IT, I'll tell you a bit more about that in a minute. Step care and collaborative care. So I'm going to go through these one at a time. Evidence-based treatments, nothing to say apart from we follow the NICE guidelines. And here's just some examples of NICE guidelines. So what happens in IAPT is mainly driven by what is written by NICE. So then we thought we have to train people, and the UK is known for having good training in cognitive behavior therapy, but my colleagues in that part of the organization were not happy with the quality of that training. So they actually set up new courses, and we set up new courses for low intensity, and the ratio was 2 workers for low intensity and 3 workers for high intensity. This was an argument I lost at the Department of Health. I would like it the other way around. What has happened is that market forces have turned that the other way around, so that now we train more low intensity workers than high intensity workers. We had national curricula. They're based on competency. This is where every country is different. So the workers here of high intensity were not all psychologists. They were all kinds of mental health workers. In fact, the smallest group was psychologists. So these people are doing traditional CBT or interpersonal therapy, and a lot of nurses, a lot of occupational therapists, some social workers, some clinical psychologists, but very mixed group of people. It's a great opportunity for mental health nurses in the UK to earn additional money, because you get paid more to do the job of high intensity, which is another problem, or not. Okay, so these are just the curricula. And we produced a lot of training materials, which is free for if anybody wants to download them, you can go and get them. There's no copyright. We call it copyleft. You can get these. You do have to buy the book. I'm sorry, it's not free, but everything else is free. What we do with these people is we do a lot of clinical simulation in the university. HEI is a university, and then they get practice in the workplace. And the new group doing low intensity therapy we call psychological well-being practitioners, PWP. Okay, they never existed before 2008. Now there are about 3,500 in England, in the UK. And if you had a professional qualification, you could do this course, and you could do half the course. So half the course was for specific competencies to do low intensity therapy. And so we would sit and we would do role play and simulation, the kinds of, you know this stuff in the training. So it's not a theoretical training, it's a very practical training, and then people go out and see patients. Once they pass competency tests, so we video them, we pass them, and then they can see patients. So what about smart IT? Smart IT is very important for this, and we had to invest some money in information technology. Part of the reason is because clinical data needs to be collected at every contact with a patient. This is a big challenge for many traditional workers who think it gets in the way of the therapeutic relationship, getting a patient to fill in a questionnaire. Actually, patients really like it. The feedback is, they like to fill in the PHQ-9 and the GAD-7 and then discuss it with their therapist, even on the telephone. But the point of doing it is that you can use the data to trigger alerts, trigger supervision, trigger risk alerts, and that supervisors and supervisees see the same data at the same time. And this system I first saw in Seattle, and we reprogrammed it and brought it into the UK. And here we are, this is what it was called. We developed it at the University of York, and it's now used internationally for these kind of systems. Okay, I don't know if people know about step care. I'll tell you about step care. It was developed as a means of trying to manage volume whilst keeping treatments working. It has two principles. I'll spend some time on this. Least burden, self-correction. Very important. You know, learning objective, self-care, step care, least burden, self-correction for this talk. And the first is that we should give patients the least burdensome, least restrictive treatment for the maximum outcome. So if I hurt my back, I do not get referred to surgery. I maybe have some antispasmodics. I would continue to be given a physio program if necessary. I probably have no treatment at all for 5 days. That's the current guidance. But what if my bad back persists? Okay. So that's the second principle, self-correction, which is there must be a system to find and monitor my symptoms over time so that I can be stepped up to the next intensive treatment. Mental health services were very bad at doing this. There was no real rigorous system for connecting that up. And this is what you need in a step care system. And it's a challenge to implement. I work with some mathematicians, and I was doing some modeling of patient flows in the health system, and I explained step care, and they said, okay, well, this is what you mean is the original system, Dave. And I think it's very funny that they think psychological therapy happens like this, in the old, you know, lying on a couch and somebody's sitting behind you. And so in a traditional system, mostly my anxiety and depression is managed by the GP. Some people get referred, a small, tiny number, and you get a choice. Some people never turn up, quite a lot. But then some people go and have therapy, and some people come out happy, and some people it doesn't work. About half and half, actually. So step care sounds very simple, but then you look at the diagram, it's not simple. And this is what my mathematician said. This is step care. So here is the same entry point, except that you have an assessment here, and you go for this low intensity phase. You might be happy at that, but if not, you have the option of then being stepped to the next phase. It's okay? So there's a pathway for low intensity, which is, yep, come here, have an assessment, get referred, low intensity. This, of course, does not necessarily happen like this. It may happen on the telephone or on the internet or some other way. That is the route to high intensity. So you have an assessment, you miss this step out, go straight here. You also have another route for high intensity therapy. So it doesn't work, the low intensity doesn't work, you come through here. What we want is that. Okay, there's no point in having this system if everybody goes here or everybody comes here. What we want is the majority of people finishing their time here, having gained some benefit from the low intensity treatment. And we have two really important decision points for the service. This one, here. If this person directs too many people here, the system doesn't work, it fails. Okay. If this person is a high-intensity therapist doing the assessment, we know more people come here because they practice defensively. If this person is a low-intensity therapist, they have more belief in this. More people go this way. And let me tell you that there are certain reasons why you may come this way. Severity of symptoms is not a good reason. We published in the BMJ a meta-analysis of data on how people responded to low-intensity treatment, and people with very severe problems, very severe symptoms, responded at least as well as people with mild symptoms, and maybe even better to a low-intensity treatment. So do not assume this route is reserved for people with high symptoms. It is not. Here, we need to have criteria for coming this way. And it's a very difficult question. We have not solved that question. Let me give you an example. You have a patient who improves by 50% on their symptoms. Okay, sounds good. But they still have a diagnosis of depression on a cutoff. Should they go here? Okay, we don't know. Maybe sometimes yes, maybe sometimes no. You have a person who drops below a diagnostic threshold, but still feels they need some therapy. Do you go here or not? It's a difficult question. There are no easy answers for those clinical decision-making points. The other system we use, which if there are GPs here in the audience will be pleased to know, is that we use a system called collaborative care, developed in the States, and I'll show you the diagram of it. It's in the tree system there. You will, if you read the literature, you will see all these words describing collaboration between primary and secondary care. It's a very confused picture, but I'll try and simplify it for you. This is normal, yeah? If I'm a patient, I go to see my GP. My GP looks after me for all kinds of problems, including mental health problems. But if my GP and I agree that they have done everything they can, they will refer me to a specialist. And then I will talk to my specialist, yeah? Okay, so collaborative care puts another person into the mix here, and the case manager and the GP and the patient are doing all the conversations together, and the specialist is not actually speaking to the patient. Specialists operating through the case manager. Their expertise is coming in through supervision. Does it work? Collaborative care, if you understand meta-analyses, these are trials of collaborative care published up to about 8 years ago, and the effect size there is not large, but it is certainly far larger than, say, statins or some other medical intervention. Or if you don't understand meta-analyses, these are single trials, and this confidence intervals, and this is the combination of all these trials. However, there is a problem. There's a problem for Italians, and there was a problem for British, in that all those trials are in America. So these are American, and at the top are the non-American trials, and you can see here, because this wide confidence interval means that we don't know if collaborative care was working in non-US systems. So there are now actually a number of trials in Spain, Germany, Holland. I don't know of a trial in Italy, but we got funded to answer the question, which was, in this publication, is collaborative care more clinically and cost-effective than usual care? And we published this in the BMJ last year. And just to summarize, large trial, what we were doing was providing this case manager into the system, and the case manager did two things. They provided coordination and linking with the GP and the specialist and the patient, and it also gave low-intensity psychological therapy. In this case, it was behavioral activation. So a good low-intensity psychological therapy, and it's easy to deliver, and it's easy to apply, and patients really like it. And you can see how it was done there. And then this important thing that GPs were involved in the process. Case managers, they were the same as in IAPT. They were PWPs. We gave them an additional 5 days training just so that they were using our research protocol, but it was really the same. I'm sorry about this one. This is important to know. There's 581 patients in this trial, so it's one of a very large trial of depression. You remember the systematic review had 21 trials with only 800 patients. So already this is very, very large. And you can see that we followed people up at 12 months, and we had 86% follow-up, which is in clinical trials of depression, very, very good follow-up. We aim for 80%. We got more. Okay, so I converted this from the modern PowerPoint to the old PowerPoint, and it's come up like this. I hope it works. Yes, good. Okay, so what did we find? We found that collaborative care in a UK nationalised health system produced recovery rates better than in usual care by about 15%. So about 15% more people using the collaborative care system than care by the GP and standard care either improved or responded. And I will have to say, these are percentages. I'm sorry it's not come up. So this is 40%, and recovery rates here is collaborative care, and here is usual care. Is that clear? Sorry about that. And you can see this difference. This is at 4 months, and this is at 12 months. Okay? Okay, and some other results, but the bottom one is the most important, is that people receiving collaborative care were much more satisfied with their treatment than people receiving. I'm sorry any GPs here, but people receiving the collaborative care were much more satisfied than they were with people receiving GP care. Yeah, I mean, these are secondary outcomes. So we had very positive outcomes on the PHQ-9, but that wasn't expressed in the SF-36 mental component. Yes, that's right. Yeah, yeah. Well, I find it difficult to comment because it's the opposite to what we found in the PHQ-9. It's an artifact of the measure rather than because you can see. Is there a reason for your question? Okay. Actually, I tell you, yeah. But because people are getting hot and tired, can you ask the question at the end? Yeah. It's a secondary outcome measure. You know, you see secondary outcomes working in a different way sometimes. So you expect an outcome just after treatment at 4 months. What we didn't expect was to have a persistent outcome at 12 months. That's something amazing. Okay, but it was only, it was our primary outcome where that was demonstrated. But I think the PHQ-9 is a good measure of depression. So just to summarize, collaborative care is a part of the IAPT model. We have data now, shows its persistently positive effects. It's cost effective, and I didn't show you the data because the thresholds for cost effectiveness in Italy will be different from the thresholds in the UK, but it is in our system regarded as cost effective. The government will pay for collaborative care because it is economically viable and people are more satisfied. Okay, given it's hot, I'm just going to move on. Okay, we have a lot of research on IAPT now. You want to know if it works. I have to give you a health warning. It's a personal story. You probably think because I'm English that my blood is kind of warm tea or something like that. Actually, I'm quite passionate. Curly hair, maybe I have some Italian in me. We had a change in government. I was working as an advisor to the government for 3 years. We had a change in government, and unfortunately, I got very angry with the new government and accused the government minister of lying. This was reported in the left-wing paper in the Guardian, and I was sacked as an advisor to this program a couple of years ago. I just have to say, to be honest about that. Hopefully we'll have a change in government and then I'll get reappointed, but the current government, being a sort of right-wing government, doesn't like my views. Nonetheless, we were able to do some research and important research. What we know is that in this first period when I was working for the government, that we were getting really phenomenal results. If you just read that, 1 million more people in 3 years having access to psychological therapies, who before this program would not have had that. They would have had what? Nothing or antidepressants. 1 million more people. That's a lot, yeah? In the time that we were able to get the measures, about 2/3 completed treatment. We have recovery rates consistently in excess of here, but of course 2/3 of people are actually improving, even if they're not dropping below recovery thresholds, diagnostic thresholds. This, of course, is a good story. Yeah? And we have about 4,000 new people trained to do the work. Okay, there's still a problem. It's cross-sectional data. So when you do a cross-sectional data, you don't know what's happening to the people still in treatment. It might be overestimating the outcomes. So we did a prospective study. We followed people up in one center for a year just to see what happened to them. We got every patient in it. This is why routine outcome monitoring is so important. We had data on everybody. Most studies in this field have data on about 1/3 of patients. We had data on 100%. And so we had about 8,000 patients. So what happened? So you can imagine a health system like in Trieste. You set up a system, an IAPT system, where you're seeing 4,000 patients a year with anxiety and depression. It's a similar size city where we did this study, about 250,000 people. So about half of those received 2 or more treatment sessions. You can see the uncontrolled effect size was very large. Now it's uncontrolled, so some of that will be about people recovering naturally. But this is an uncontrolled evaluation of service. That figure includes people who drop out. That's the importance of collecting data every single session, because most studies don't include people who drop out because they don't have a post-treatment measure. But if you have a measure every session, you take the last measure that you have and you include that in your analysis. So we know even the dropouts how they were doing. You can see these scores, about slightly more than half met reliable improvement. This is the same as the collaborative care trial. So, you know, in a trial, it's a carefully controlled scientific environment. This has all the noise of a normal clinical service. It's exactly the same outcomes. Very important. So we're transferring science into practice. And people achieve these improvements with about an average of 5-6 sessions per person. Much less than traditional psychological therapies, much less. And they had about 3.5 hours of input from a worker. But very high attrition. And I'm going to do this one for you. I'm going to show you what I think is the real challenge now for psychological therapies, and I don't know the answer to the challenge. Okay, so you see, this is a flow of patients through a system. At the top, this is referrals, either from a GP or in this system you can self-refer. You can put yourself forward. And then here we have assessment, where you have a conversation with somebody. Here you have treatment, and this is the outcome of treatment. Completed it, dropped out. Some people unsuitable, I'm afraid, who had to get other kinds of therapy. Maybe there was a physical problem, not a psychological problem, which sometimes comes through. And 3 people died, not from suicide, but just from natural physical illness in the course of the study. Now, I hope you can see the numbers, because between referral and assessment, 27% of people just don't appear. Okay? 2,000 out of the 8,000, we have no idea why they didn't turn up. And then this really strange mathematical thing happened. Between assessment and treatment, we lose another 27%. So people are assessed. Some people say no. Some people just want advice. Some people you never see again. Then maybe they don't like the offer. Some people here need something different. As you see, a number die, as I say. And then guess how many drop out of treatment? Really? It's kind of weird. But this is what we found. So, you know, I've given you this kind of upbeat talk, how great it all is, but it's not all great by any means. Actually, only just more than a half of the people referred got to the end of treatment and had had a reasonable dose of treatment. We lost a lot of people. And I think we are poor at engaging and retaining our patients in routine practice. This is not unusual. Any mental health clinic has this experience. Really? You must tell me your secret then, because every mental health service I know has this problem. With anxiety and depression, we lose people all the time, and only about half of the people go through to a full dose of treatment. And I think we're poor at retaining our patients in routine practice, and we need to understand what that is. Even with greater choice, even with more options, this is the same as published data from standard psychological therapies, clinics, where we still see a lot of people dropping out. So to finish, here's a definition of access. Okay, we're achieving levels of effectiveness that you would achieve in clinical trials, certainly as good as antidepressants. We are making a lot of stuff available. It's only really being used by about half the people who are referred. We have data on equity, but we are still in the UK poor at recruiting patients with different ethnicities into our services. And I don't know, we have good patient satisfaction from these services, but that's only from people who engage. So there is clearly something not right for others. So I don't think we're going to improve access with the existing workforce. My experience in the UK is we will not do that with the existing mental health workforce. We'll have to look somewhere else. And in every country it will be a different place you look. We won't improve access with the existing treatments, the traditional psychological treatments. We have to do something different. And our existing systems will not be able to change to deliver these new treatments with these new people. We need different systems. Step care, collaborative care, important. Probably with the guidelines that we have in existence, we will not improve access. The data from Australia tells us a terrible story about wasting money. They pumped a lot of money into a fee-for-service psychological therapies system, and the evidence of the data from that analysis is very poor. So in an Italian system or an NHS UK system, you probably have a better chance of improving access than you do in a liberalized economic type of system. So you're already starting in a better place. And I think what you need to do, if you're trying to do this, this is a message we give globally, you need to put in place systems to ensure treatment fidelity and worker competence. What happened in Australia is that they assumed all the therapists out there were using evidence-based treatment and were competent in whatever treatments they were doing, and that was proven not to be the case. You need, I'm afraid, somebody once put a picture up of me and a picture of Stalin together on a slide and said, we need more of him in order to make the systems work. It was a joke, of course, but in other words, some direction. You can't just leave it to the market. The market won't respond in the way that you want. People will do anything to get paid as a therapist, and that was the Australian experience. We do have this massive problem with attrition. If you can solve it, I think you deserve the Nobel Prize. You have to ensure high levels of data collection. You have to convince your therapist that it's okay to give patients a short questionnaire on symptoms every time they see them or every time they talk on the telephone. You have to work for equity. You have to look for disadvantaged populations and work with them. And I think we need to think harder about acceptability. However, I think this is a big change. Big change in 4 or 5 years in the UK. It's no longer the case that if you're depressed or anxious, you're excluded from participation in meaningful relationships, work, etc. You're no longer told you're unsuitable. You know, you're not bounced out of the nightclub. You're brought in. And it is certainly true that we regard, it was written, I think, in one of our journals, that the introduction of IAPT into England was the equivalent of closing down the asylums in terms of mental health service change. Was the second biggest event in mental health care in my country. And that's it. IAPT has changed the landscape of mental health care in England, or has it? Okay, so here's a final utopian vision which I'd like to present to you and see what you think. I spotted this in a hairdresser's in my hometown. I loved it. I thought the message in the advertisement was fantastic. It says, 26 quid for a funky cut and finish. A shoulder to cry on is free, and you can scan through the mags for free. And I just thought, well, what a message. If, as well as Bella and Hello and all these magazines, there was a book on managing your depression and anxiety. If the hairdresser, my wife goes to the hairdresser every 4 weeks for colour. If If she didn't turn up on 4 weeks, the hairdresser calls her up and said, "Oh, I just noticed you didn't come. Are you okay?" If you go to a hairdresser, hairdressers hear everything. But how about hairdressers know how to say things back? Know how to say, well, have a read of this. This might help. And, you know, do you know there is one study which shows that if you train hairdressers to be active listeners, the mental health of people having a haircut improves. So this is not just a fantasy. This would be proper improving access to psychological therapy, and one day I would love to be able to see this happen for real, and then mental health care is away from the asylum and is completely in places where people go. So, thanks very much.